sympathy. No, I'm trying to be the best girl I can be. It's very simple, but I'm just another girl. It's not so easy, but I'm giving it a whirl. Like my martini stride, cosmos I won't deny. Smoke those long cigarettes. Thank God I'm not dead yet. Done all these crazy things, short of a wedding ring. Just
Good evening. Thanks for joining us. I'm Callista Solon, and you're watching NLC Trans. Tonight I'm here with my dear friends and co-hosts, Tara Alexander and Renee Benoit. And we have a special guest tonight, Aaliyah Nestaby, and you are a nurse practitioner. Mm-hmm. I'm going to sort of ask you to sort of give our audience kind of a rundown on what you do. Sure. and how you do it and exactly what a nurse practitioner is. Mm-hmm. But you deal a lot with trans issues, which is very interesting. But maybe you could just give us kind of an overview of what it is you do.
Sure. So I'm a nurse practitioner, which means I'm a registered nurse with several years of advanced training. So I'm trained in doing primary care. There's various areas that nurse practitioners are trained in, but I do primary care. I work with adults in a community health setting. And trans health and LGBT health is an issue or interest of mine. So I've been sort of cultivating that work, but it's in the context of adult primary care. So I provide primary care to all kinds of folks.
Very good. So do you see a lot of LGBT patients?
Relative to other providers, yes. I don't have a huge practice, so I'm not seeing as many people as you might find at like Fenway in Boston or Mazzoni Center in Philadelphia. Sure. But as one provider, I have several dozen trans patients and LGBT patients. So
well, that's
more. It's more than most people see.
Yeah, that's actually pretty impressive. I know there are. It happens that you find doctors and medical care professionals that sort of are trans friendly and LGBT friendly. Not that most medical care professionals aren't, but there are sort of certain people that we all kind of.
There are the networks.
Yeah,
your friends talk about it about a doctor that they like, and you try to get in there.
Yeah, that happens a lot, but that's a pretty large number actually when you consider. I mean, I think in all fairness, there are more of the us than people realize. Mm-hmm. It's like a line from Transamerica that I'm very fond of is the "We walk among you" line. But there are more of us than people realize, and. Mm-hmm. And so it's, I don't know how the numbers exactly play out for healthcare professionals, but that is a fairly impressive number. And you see a lot of people within the broader LGBT community as well, obviously.
I do. Yeah, my community health center is located in Springfield, so aside from people that sort of seek me out for LGBT healthcare, I see people from the community, and that includes a number of LGBT folks as well.
Yeah, very cool. Well, let me ask you. Mm-hmm. So you see, quite a few people, and obviously you have an interest in this. What kind of issues do you if you can talk about that? What kind of issues do you see with trans folks?
Well, I think the biggest one that I see is people looking for a hormone provider, because I think in the area that I'm in, which is sort of close to Connecticut and near the Pioneer Valley, there's a fair amount of therapists, not a ton, but a good amount of therapists that you can find with some gender experience, but there's actually not a lot of people that will provide hormones. So that seems to be the number one thing that people are looking for. And then second to that is just people that haven't been receiving primary care. So people looking for primary care from a provider that's sensitive.
Very, very interesting. Certainly, yeah, we kind of The WPATH rules, the Harry Benjamin rules, you know, it's all
Standard.
pretty standardized in black and white. But it's interesting that that we don't completely follow them as far as, I mean, we follow them, you know, sort of in principle, but the doctors seem to be not always what you expect. I mean, so it's who's doing what is not always. Sometimes the lines can be kind of blurred, which is interesting. But in fact, I saw my endocrinologist yesterday, who was in fact an APRN, and up in the
New Britain now.
New Britain General Hospital. It is actually probably going to come on the show at some point. I don't know that you would know her, but
Yeah, I don't think I do. I'm not sure if we've ever met in passing, but
yeah,
I don't know her. I don't think.
But it's an interesting thing, and so obviously you would be familiar with the WPATH and the standards of care, which is the for our audience the sort of the rule book by which we go through transition. Post-transition, obviously, the rule book can kind of go out the window. Not entirely, but to some degree. But we sort of have to follow that path, which is now WPATH. It used to be, and still is commonly called the Standards of Care of Dr. Harry Benjamin. But
And WPATH's short for the World Professional Association for Transgender Health, if anyone's looking for that.
yeah. It's all, it's interesting how sort of organized all of this has become and how much information there really is out there. So, but you have a pretty significant number of patients. Obviously, Springfield is a fairly urban area and fairly large population.
I just wanted to ask you something about, we attended the Health and Law Conference a short time ago. Were there any from that conference that came to see you?
You as patients, you mean?
Yes.
I've had a few patients sort of connect with me through conferences.
Okay.
Yeah, definitely. Sometimes people will see me talk and ask if I'm taking new patients because they're looking for a provider. So I think I've come across patients that way, word of mouth, the internet. I have some therapists that give me referrals in the area that I'm in. So all different avenues that I get people.
Yeah, it's really important to have primary care with somebody that sort of is at least sympathetic, but somebody that sort of understands. Is really kind of comforting. We've all been fairly lucky as far as finding medical professionals. This part of the country seems to be pretty good for that. Certainly, I have talked to a lot of people that have had trouble, finding good medical professionals to sort of oversee the whole trans thing. But it's I think it's getting easier, and so it's really kind of nice that there are understanding people. And I have to ask you, there's some really cool tattoos.
Oh, thanks.
I'm kind of a gardener, and so I'm kind of admiring your plants and things.
Oh,
in your
thank
room.
you.
It's kind of very cool. But anyway, I'm sorry. I'm like a magpie. I get distracted.
Squirrel.
Stop it. But anyway. Yeah, so we've all been fairly lucky down here, but I know, it really is very, very important.
I think something that's sort of interesting about what I do too is that I'm a primary care provider, but I provide hormones for some, I would say most of my trans patients, not all. And that's kind of unusual to find. I think traditionally it's been done through endocrinology.
Yes.
Right. Yeah.
But, and endocrinologists do have a much deeper breadth of knowledge about hormones and very complex things related to hormones in the body. But at the same time, they don't receive any more training about transgender issues than most medical providers do. So, in my opinion, it's for people that are generally healthy and well, hormone therapy can be managed in a primary care setting, which is a little bit of a shift I think it's a newer shift, but it's a shift away from the standard endocrinology model.
Right, right.
So I have both. I have patients that see me for hormones and primary care, and I have some patients that see me solely for primary care, and they have an endocrinologist that they go to.
Yeah, I have, talking to some of the folks that we know that are going through it, I know some folks get their hormones through their OBGYNs. Some folks get their prescriptions through their primary care therapist, but see an endocrinologist for monitoring and care. It tends to be a real interesting mix.
Yeah, and I think it's not as complex as people might think it is to monitor hormones. There's some guidelines that have more recently come out. So the Endocrine Society published some guidelines in 2009, and there's some other guidelines that have been published. So there's a little bit of information to go on now, whereas 10 or 20 years ago there wasn't as much.
Right.
So it's not, as some people would say, it's not rocket science, but I think you'll find different people have different opinions about who should be monitoring or prescribing.
Yeah.
It's pretty important stuff, though. It's not. I mean, maybe not rocket science, but it's pretty important.
You do want to get the balance right.
Yeah. It's amazing what hormones can do. Obviously, you know this, but it really is amazing, and so it can be kind of scary.
Well, on that, do you want to talk a little bit about the hormones that get used during a transsexual transition, the effects they have?
Sure.
As an education point?
Certainly. So I'll go over first male to female transition and then female to male transition. So for male to female transition, typically you have what's called an anti-androgen or androgen blocker, and that's a medication that sort of helps to stop the effect of male hormones in the body. And usually that's spironolactone. That's the most common one. That's also a diuretic, which is a water pill. That's another use for it. So it's used to treat blood pressure at times. And then along with that, you pair that with estrogen or estradiol. And that comes in a variety of forms. So that could be oral, which is a pill, could be injectable, or as a transdermal, which is like a patch or a spray. And so those two things are prescribed together. If a patient has surgery, which involves removal of the testes, so that's either orchiectomy or a vaginoplasty, then they no longer need the androgen blocker because the body's not producing androgens anymore. So usually at that point, the spironolactone is stopped, and then the estrogen is continued. And there's also progesterone, which is, as I was saying to you earlier, kind of debated within the community and within the medical community about whether or not it's necessary. Some people say yes, it's helpful. Some people say no, it's not helpful because it has side effects, and we don't know that it works any better than not using it. So you'll find people on both sides of the fence for that medication.
Okay. Yeah, low dose progestin may or may not help alleviate some of the estrogen side effects.
Yeah, and some people feel that it's important for breast development or nipple development, and other people, again, say not really. And there's two forms of progesterone, which are Provera and micronized progesterone, and those are both used in this country. So that's sort of the quick.
Isn't the Provera, as far as the insurance companies, they tend not to want to pay for that because it's more expensive, or?
The Provera?
Yes.
Provera is the cheapest.